All right, let's get into it. Today, we're tackling a big one, diabetic ketoacidosis, or DK. And this isn't just about high blood sugar. No, this is a full-blown metabolic crisis. We've put this guide together specifically for nursing students to really break down DKA so you understand just how crucial your role is in turning this whole situation around. Let's dive in.
So, here's our game plan. We're going to follow a patient's journey, right from the moment they hit the door in crisis to when we're planning their discharge. We'll start with what DKA actually is, then look at the chaos happening inside the body. We'll learn how to spot the clues, walk through the main treatments, and then, importantly, we'll organize it all into a nursing care plan. We'll wrap up by looking at maybe the most important part of our job, prevention.
First up, the crisis. I really want you to understand how serious DKA is. This isn't something that simmers for weeks. It can develop really fast, sometimes in less than 24 hours. And if we don't treat it just as quickly, it can lead to some truly terrible outcomes, like circulatory collapse or cerebral edema. This is exactly why your quick thinking and fast actions are so critical. To really get DKA, let's start with a basic question. What actually happens when the body's main fuel system just fails? I want you to imagine your cells are absolutely starving for energy, but at the same time, they're literally floating in an ocean of sugar they can't use. That strange and dangerous situation? That's the heart of this crisis.
So, what's the official definition? Well, DKA is basically a trifecta of metabolic disasters happening all at once. First, you have hyperglycemia. Blood sugar is through the roof because it's locked out of the cells. Second, you get ketosis. Because the cells are starving, the body freaks out and starts burning fat for energy like crazy. The byproduct of that? These acidic things called ketones. Which leads us to number 3, acidosis. The ketones build up and make the blood dangerously acidic. Hyperglycemia, ketosis, and acidosis. That is the DKA's signature.
Okay, so now let's dig into the cascade. This is the pathophysiology, the why behind DKA. And trust me, once you understand this sequence of events, all the symptoms and all our treatments will make perfect sense.
The best way to think about it is like a series of dominoes. It all starts with domino number 1, a major lack of insulin. Without insulin to act as the key, glucose can't get into the cells, so it just piles up in the blood, causing hyperglycemia. The body panics because it's starving, and that tips over domino number 2, lipolysis, which is just a fancy word for breaking down fat for fuel. This breakdown releases fatty acids, which head to the liver and get turned into ketone bodies. That's domino number 3. And as these acidic ketones flood the system, the blood's pH plummets, causing domino number 4, metabolic acidosis. At the exact same time, all that sugar in the blood is causing what we call osmotic diuresis. The kidneys are working overtime, dumping sugar into the urine and dragging tons of water and electrolytes out with it. And that leads to massive, severe dehydration.
So with that whole cascade going on inside the body, what are you actually going to see at the bedside? This brings us right to our next section, the clues. This is where your assessment skills are everything.
Your patient is going to show up with some really classic signs. That osmotic diuresis leads to polyuria and polydipsia. They're peeing constantly and are unbelievably thirsty. The acidosis often makes them feel sick to their stomachs, so you'll see a lot of nausea, vomiting, and even bad abdominal pain. Of course, they're going to be weak and exhausted. And then you have the 2 big ones you can spot without any equipment. A fruity, almost nail polish remover smell on their breath, that's acetone, and Kussmaul respirations. That's that deep, fast, labored breathing. It's the body's last-ditch effort to blow off acid in the form of CO2.
Okay, so your assessment makes you suspicious, but it's the lab work that gives you the proof. The diagnosis of DKA is pretty much confirmed when you see blood glucose over 250, an arterial pH less than 7.3, and serum bicarbonate below 15. The final piece of the puzzle is finding moderate to large ketones in their blood or urine. When you see that triad of lab results, you know for sure what you're dealing with. As soon as DKA is confirmed, it's go time. We launch the counterattack. The management is aggressive, it's fast, and it's built around 3 pillars of treatment that we do all at the same time. Those 3 pillars are fluids, insulin, and electrolytes. First, we hit them hard with fluid resuscitation, usually isotonic saline, to fix that severe dehydration and get blood flowing to the tissues again. Second, we start a continuous IV insulin drip. This is what's going to stop the body from making more ketones and finally allow the cells to use all that sugar. And third, we have to carefully replace electrolytes. That diuresis and the insulin therapy cause huge shifts, especially with potassium. Remember, these things aren't sequential. They're all happening at once, and they're all equally important.
Now listen up, because this is a safety point you can never ever forget. You absolutely must know the patient's potassium level before you start that insulin drip. Why? Because insulin shoves potassium from the blood into the cells. If you start an insulin drip on someone who's already low on potassium, you can cause their levels to bottom out, triggering a fatal cardiac arrhythmia. If their potassium is below 3.5, you fix that first. This is a non-negotiable rule.
Okay, so we have all this information. Let's get organized. As a nurse, the way you structure your work is through the nursing care plan. This is how we take everything we've assessed and everything the doctors have ordered and turn it into a prioritized plan of action.
Priority number 1, without a doubt, is the nursing diagnosis, deficient fluid volume. This ties directly back to that massive osmotic diuresis we talked about. This patient could have lost a huge amount of their body's fluid.
So what do you do about it? Your interventions are pretty straightforward, but they are so important. You'll be hanging and managing large volumes of IV fluids, starting with normal saline. You've got to be meticulous about tracking their intake and output to see how they're responding. And you'll be doing frequent physical checks, looking for better skin turgor, checking if their mucous membranes are moist, and making sure their vitals are stabilizing.
Our second diagnosis is ineffective breathing pattern, and this is all about those Kussmaul respirations. And remember, this is not a lung problem. This is the lungs working overtime trying to compensate for the metabolic acidosis.
For this, your role is mainly supportive. You're going to watch their respiratory status and O2 sats like a hawk. A simple thing like raising the head of the bed can make a huge difference, just by giving the chest more room to expand. And we often give a little supplemental oxygen, not because they're hypoxic, but to reduce how hard they have to work to breathe while we fix the underlying problem.
Okay, our third diagnosis gets to the real paradox of DKA, imbalanced nutrition, less than body requirements. Think about it. Their blood sugar could be 500, but their cells are literally starving to death because they can't get to any of that fuel.
The key intervention here, of course, is that IV insulin drip. And you will be checking their blood sugar every single hour to make sure it's coming down slowly and safely. Now, here's a super important point. Once their blood sugar gets down to about 200, you're actually going to add dextrose, sugar, to their IV fluids. I know it sounds crazy, right? But what this does is it lets you keep giving them insulin to fix the acidosis without accidentally making them hypoglycemic.
So those are the problems the patient already has. Now let's talk about the problems we're trying to prevent. These are our risk 4 diagnoses. And the biggest one by far is risk for electrolyte imbalance, especially focusing on potassium. The disease itself, plus our treatment for it, creates a perfect storm for dangerous electrolyte shifts.
Your role here is all about vigilance. You'll be watching those lab results come in, staring at that potassium level. You'll have the patient on a cardiac monitor, looking for any EKG changes like flat T waves that scream hypokalemia, and you'll be giving potassium replacements as ordered.
And finally, our second major risk for diagnosis is risk for decreased cardiac output. This is really where everything comes together. That severe dehydration combined with major electrolyte shifts can absolutely lead to cardiovascular collapse. To stay ahead of this risk, you're going to be doing frequent hemodynamic assessments. That means you're all over their blood pressure and heart rate, you're assessing for signs of shock like a weak, thready pulse, and you're checking their peripheral pulses and capillary refill to make sure their tissues are getting enough blood. You are the first line of defense here.
We did it. We've navigated the crisis, but our job is not done, not even close. The final, and maybe the most critical part of your role is to make sure this never, ever happens again. And that is all about prevention and patient education.
You know, in the middle of a chaotic DKA admission, it's so easy to just focus on the tasks. But I want you to leave with this thought. While managing DKA is a huge team effort, the role of the nurse is absolutely central. From that very first assessment to the final discharge teaching about sick day rules, you are the key. You don't just save a life today, you empower your patient for a much healthier tomorrow.